We are just directly moving into the next session, cases and complications. And George, Dr. Our friends from Zajcer.
Hello to everyone. First of all, I will put my glasses so I look a little bit smarter. And on the other hand, I can only thank you for the opportunity for us to be here and for the opportunity for us to show our mishaps. When I was thinking about the headline for this case, maybe I should headline it, please don't do this at home. So without further ado, I will show, let me say another thing. I'm working in a very small volume center, but we used to kid ourselves that we make complications like a higher volume centers. So let's see what we've done. So this is a female patient, born in 1964. Meaning she's at the moment of our intervention around 60 years old. It was treated as an ACS non-STEMI at our local known Catholic hospital. Prior to admission, she had ACT changes, ST depression, chest pain, let's say some lower levels of high sensitive troponin levels elevation. And after that, during the echocardiography, you have preserved ejection fraction, hypotoakinetic basal segments of posterior and lateral wall with subsequent hypercontractility of other segments. She's a diabetic, of course, hypertension, hyperlipid, and hypothyroid with hyperlipidemia, which all complicates the whole thing. Without further ado, we done angio, so for now, it's okay. Viewing the left system, you have the left anterior descent, maybe you have some 50% in the upper segment. But when we see the right coronary, I cannot say for myself that I'm not an inexperienced guy, but for the colleagues from a high volume center, probably I am. So when I saw this right coronary, okay, we'll try our luck. So why this a kitten? It's like a kitten when it sees a bunch of sausages. And there is a saying in Serbia, I tried it to translate in Bulgarian, what is a calf's head for a kitten? Kitten meaning that this kitten has maybe swallowed much than it can chew. So we tried first with the support of the balloon. Why with the balloon? Because microcatheters are quite scarce in our facility. You have a 0.85 balloon, you have Whisper S. And at that point, I didn't quite remember the words of Professor Louvard, who said one time when I was much younger, when I listened to him, mind the tip of your hydrophilic wire. Why? You'll see in a further review. So I was quite persistent. And look at the tip of the wire. I've gone somewhere. So again, predilations, and actually I saw where the actual flow of the artery is. More again, the wire is not still where it should be. Finally, we put the wire in the distal artery, exchanged the wire, and put an Asahi Seon Blue, which is good for this patient, you'll see why. So, distally, I put a stent by a Frieden 2.7 di/4/8, 20 atmosphere, 30 settings, and you can see the circle down there. We see this, as a professor would say, a puff of contrast. So in 90% of the cases, we've watched our, let's say, higher volume colleagues that do something like this during the CTO. But the main drawback is that you're seeing this mainly in the left ventricle, mainly in the left ventricle septum. This is right ventricle free wall. And this is the culprit. So I put another stent proximally, dilate. Again, you see what's going distally. And this is probably the position where my previous wire was. The final angio looks good. The kitten is smiling. She swallowed all the sausages. But a couple of hours when I was sleeping at my home, my colleague from the roll call says the woman is not good. She's hemodynamically unstable. the tension is falling, she is intensive diaphoresis, pale, irrespective of intensity rate of crystalloid infusion. So the woman is not so great. So the kitten is a little bit baffled now. And I am not an ultrasound guy, but luckily my colleagues are. So when we do this, we have something that is not so, well, not so common. What is this structure? I asked myself. Looks like something adherent to the myocardial wall. Echocardiography showed a significant pericardial infusion, at first with no elements and tamponade. On the other hand, there is structure adherent to the right ventricle. This dimension is around 35 by 40 millimeters, which in turn actually compresses the whole right ventricle and making ventricle obstructive shock. We use MDCT orthography. Unfortunately, our CT scan is around 16 slices, so not so very good for the heart, but it served the purpose. So at our left, you can see the dimensions of this hematoma. The only thing that was luckily to this one is that we didn't make a dissection, so that was the luck in all the mishap. So, where's the sound? The sound. David, давай ga pa. What should we consider? Ritual suicide? Maybe. But what are the statistics? The perforation rate during the CTO is around 5.7%. The tamponade rate is 0.2. I was a little bit comforted when I watched through the literature and saw that there is only one work citing this. Both cases were at the right coronary. So I was, let's say, comforted that I was the only one, but that was not so often. What should we do next? Surgery, current stent, pericardial synthesis. Before we decide, I like to show this picture, which is our distance to Belgrade, around 2 hours, 50 minutes. To Niš is around 1 hour, 50 minutes drive, if you're very, very quick enough to organize the transport. If you decide to go to the European Union, the nearest cardiosurgery center in the EU is Sofia, is around 3 hours, 23 minutes. So we're in trouble anyway. So what would you do in this case? And what we decided to do, luckily we made the small consilium. All of three interventions were there. So we were, let's say, trying to decide what to do with the patient. This is on-site actually echo. Vlada was filming it with his phone. And we decided to go with the pericardial synthesis regardless of the fact that actually the effusion itself wasn't so big. And luckily the one above had his hand over us, so we did an urgent pericardial synthesis, subcephalic approach under fluoroscopy control. Some 140 milliliters of blood was derived, rightly infused back, and luckily we called our teachers. After the procedure, the hemodynamic effect was almost instantaneous. The patient was hemodynamically stabilized, and in such a manner transported to a tertiary center. What comforted us is that the fact that even there in Belgrade, the patient received conservative care. And this is the proof of life. This is the discharge letter from Belgrade, which shows that the patient was successfully discharged without any surgical or invasive treatment. And I can only thank you for your attention and invite you to our Congress in November 2026 on Stara Planina. Thanks again.
A great case, and really a great demonstration of what can happen with the peripheral, distal perforation. And especially in such cases, our experience is if you see something, there is a saying, see something, do something. Probably a small coil in this branch will seal the will thrombolize the
Probably
vessel, and it will make it much more easier.
one of the things that was on the table actually was a cover stand in the origin of the branch.
Yes,
So
I mean, cover stand is something else, but you already put it two stands, and sometimes cover stand is not working
Yeah.
well. And cover stands are associated with a great number of restenosis and reocclusions. That's why you have to treat the vessel before to put over the cover stand, the drug-eluting stents.
Yeah.
If you have the, in this small vessel, you can go very easily with some experience. I'm pretty sure, of course, this is not true that you are not experienced, you are doing great work there. Very easily, technically, you can go with a small microcatheter and should go into the proximal part, put a small core, forget, even not the core, some adipose tissue or something else. Because this perforation, they are not forgiving.
especially in the right ventricle.
Well, the comment was going. This was an ACS, and it was an acute coronary syndrome.
No,
correct?
after the SES actually it
Yeah.
was a non-STMI, but let's
And
say the mild one, if you can say like something
And you
like this.
used what wire?
Whisperers.
Yeah,
With
that's
Percy
what I
support.
was going to say. If you go with a more, so you took a polymeric wire and you supported the wire by
Balloon.
So essentially you went into the non-conventional ACS approach.
Yeah.
And you might not have microcatheters, which is fully understandable, but you have guidings
Yeah.
and sheets. And that means that that's what I'm always saying to the meetings. The safest way is that you put a contralateral injection in these kind of cases. If you really have to face the case in a more aggressive way from a standpoint of view of wires, then you put the safety by doing simple, small things.
Contralateral injection, yeah.
Otherwise, the safest thing here, you would take a normal wire and then you try to wire the vessel in a conventional way. And I think that you would have succeeded because it was rather fresh material.
Actually,
But if you don't, that's what I say. Take a BMW, take a run-through, and try to wire it. You don't succeed with that, then take contralateral injection and do the same thing as you did now. But this would have helped you to avoid the complication. Otherwise, it was a good, very good approach. And this was a combination of a hematoma in the free wall of the right ventricle plus
the bleeding into the
bleeding.
pericardium,
And
yeah.
I do believe because the right ventricle was compressed by the hematoma, in a non tamponade level, a small amount of pericardial collection
was enough to hemodynamically
actually
compromise the patient. Yeah.
hemodynamically compromised her. So essentially, when you remove the blood, which was the very right thing to do, is solve the problem. So it was not the hematoma causing the tamponade, but it was compressing the ventricle enough to allow even a small vessel, a small collection to do. So simple things if we follow, because my major complications, maybe I will present them one I had when I consider again in this kind of recent ACSs, you see a case that is occluded and you underestimate that. And I had a case that I went into the pericardium and dilated the vessel with 2.5 balloon. Imagine the hole that I made. It was corrected finally, but it can happen in these cases that you underestimate its emotion.
It's a basic rule. You should not advance the wire unless you have a good visualization. And what we are doing in acute coronary syndromes, if you go there because there is no collaterals and you are not sure where you go, put a microcatheter and make a small puff and see where is the vessel. Is it a big, is it a small vessel as it's here? Where is the distal part of the thrombosis? And that makes you more comfortable, more secure.
Maybe the biggest mistake was pretty aggressive management of the tip of the wire. Maybe if I pulled back the wire a little bit back,
the issue is that you haven't realized that it is a small branch.
Yeah.
It is, in a way, probably following the course of the vessel parallelly, and you, or let's say, you are convinced that you're in the right vessel. So, any more comments? Thanks. Thanks a lot. Alexander, thanks. Thanks for your contribution. And now, Dr. Borisov with the case that he is going to present.
Dear panelists, dear colleague, I'd like to present a case of 76-year-old female who presented with acute coronary syndrome, with history of arterial hypertension, diabetic, on oral medication, and past intervention in LAD and right coronary artery with stenting. She had good ejection fraction, but severe ECG changes. We performed coronary angiography. You can see from the image that we have severe stenosis at the ostial LAD and circumflex. The ostial LAD is where the stent was implanted 6 months before. Circumflex lesion is de novo lesion. On the other hand, we had instant restenosis in the right coronary artery. This is a 3D model we created, which showed large triangulation between LAD and left circumflex. So we decided to go for intervention. We cannulated left main with XB 3.06 French and wired LAD and left circumflex, predilated circumflex, predilated LAD, and on the right you see our results after predilation. At this point, we decided to go for provisional stenting of left circumflex out of left main to LAD. And firstly, we put it a paclitaxel-coated balloon in circumflex artery. And because the result was unsatisfactory, we put a DES 2.024 in left circumflex artery. And this is our stent enhancement after stenting. As you can see, we didn't cover completely our left circumflex ostium, which was for purpose. Then we stented from left main to LAD with 3.5 stent, which shows resolute onyx because it allows for pot up to 5.0. This is a pot with 4.0 balloon in left main. And this is our result after 2 stents implantation, which is a good result. And this is our stent enhancement when he went for kissing left main, left circ artery. This is kissing balloons. And after that, a second lesion in LAD was noticed. Again, restenosis, instant restenosis, addressed with paclitaxel-coated balloon. And this is stent enhancement after ballooning of middle left artery, left descending artery restenosis. And this is our final result of left main and middle LAD intervention. Good outcome. Patients was without complication, and discharge was 3 days after the procedure. 1 month later, patient came back for right coronary intervention, and we did coronary angio of left coronary artery, which revealed that we have good 1 month result. In the left main, left circ, left LAD, and mid LAD. This is IVUS 1 month later, with a bit of suboptimal result for LAD, good result for distal left main, and this is osteo left main. We couldn't pass with the IVUS catheter to left circ to see how the ostium is, but we achieved stent enhancement with IVUS catheter, which showed good expansion of left circ stent. Looking at the literature, we can see that left main bifurcation stenting is a job which has a lot of complications in terms of revascularizations at 2 or 3 years, which is true for all studies and as well for the last study, EBC main. In this regard, could be drug-cooled balloon in place of putting stents at the left circumflex ostium. DCB has advantages, homogeneous drug transfer, which Professor Gelev showed, absence of inflammatory polymers and permanent implants, absence of permanent implant at side branch ostium, and eventually possibility of dual antiplatelet therapy. So we generated a hypothesis, could the dilatation of the side branch ostium with DCB allow for two-stent strategy without stent struts at the side branch ostium? This could be true only when the side branch ostium is without dissection and or significant recoil, more than 40%. Lack of stent struts at the side branch ostium facilitates kissing and side branch pot if needed. Long-term results are excellent based on our personal experience in terms of stent thrombosis and restenosis rate. And my proposal is for trial which could provide robust outcome data on this hypothesis. And this is my last slide, and I'd like to thank you for attention.
Thank you very much. A great case, and congratulations not only for the case, because I have the feeling that you have the taste using a lot of drug-coated balloons. And to tell you frankly, we have seen randomly a lot of patients that were treated like this, and the results were excellent, really, even in cases with acute coronary syndromes. Mm-hmm. And this was really a challenging case, in my view, because there was a great mismatch between the diameter of the left main and the two other vessels, and finally it was solved quite well. And you can see the result. I'm pretty sure the long-standing results will be fine. Any comments? It was, in fact, the beginning is it was something like classical T, but with the help of the stent enhancement, it is clearly seen that the stent was positioned very, very well, and probably this is sorry, George, this is a good option, in fact, to use a drug-eluting balloon to pre-treat the ostium in case you have not covered the ostium with the stent, so you probably this is a hypothesis, so you prevent this pinching of the circumflex and.
A good stent enhancement is like it was recognized to give exactly the same information by Akiko Maya with comparing with IOS. Yeah, this is written. So a good stent enhancement can help a lot.
Probably depends on the machine because we have something and this it is not that new that necessary.
This is very good.
I think Goran Stankovic yesterday made the point of the osteocerebral stenosis. And the point is that I suspect that you intentionally avoided to stent
Yes.
the ostium of the circ.
Yes.
So this is a case that you have a complex scenario, if I interpret well the spirit, that you have to do V-stenting, but you don't want to mess up too much the stents over the carina. So you leave a little bit of a small gap. So the point is not about the imaging in order for perfect placement. It's imaging to leave a minimal uncovered ostium circumflex that you compensate, so you minimize the complexity of the metallic neocarina. You apply only DCB in this millimeter or less that it is missing. This facilitates kissing and makes the procedure more simple, and you still apply drug over there. So it's a point of simplifying the stent, so you don't even do micro or nano crush as you're calling it, but you avoid metallic overlap of the carina, and you compensate for that with DCB. It's a concept, it's an interesting concept. I have to say that I never thought about it. It is an interesting concept to avoid, let's say, even nano crushing. And even if in cases that you try to do a tap or a perfect T or whatever, or almost perfect T, that it is not always successful, and then you will leave a gap with that, you might at the end say, okay, I will do some DCB at this ostium.
We were speaking about the immediate result, but if you do a tap, my question is, okay, you do a tap, it's very nice, but if you should treat in the future the circumflex distally, you're not sure that you're going to go through the right struts. And
It was discussed, I think it was yesterday or the day before, to open, after crossover stenting, to open toward the circumflex. Some people, like in Korea or in Seoul, they are not opening the cell towards the circumflex. But Marie-Claude Maurice, my colleague, had a case to treat a big marginal branch. She was unable to cross, to return to the... And another thing, which is, this is nearly a joke. I was asked a long time ago to make an editorial comment about the case of Antonio Colombo. He proposed to the journal, was CCI maybe, he proposed a case with 6 layers of stents. 6 layers of stent. You will find that, 6 layers of stent. My name, Colombo, you will find that. Was, fortunately today we are more reasonable. So, but we can be even more reasonable to limit the number of stents. This is what I think since a long time ago.
Okay.
thanks.
Okay, thanks.
Next case, Dr. Alexandrov. It is from National Heart Hospital.
Dr. Zelepi.
And I have the pleasure to present you a case we had a few months before with a patient with intracoronary lithotripsy with shock wave in an LAD with anomalous origin of the left main coronary tract from the right coronary sinus. So this is a case of an 80-year-old female patient which presents with worsening chest pain during physical activity and reduced physical capacity during the past few months. She had 2 episodes of syncope, while Holter monitoring registered a few episodes of non-sustained monomorphous ventricular tachycardia and episodes of sinoatrial block. So what's her medical history? We know that she has an ischemic heart disease since 2015, where one drug-eluting stent was implanted in the right coronary artery. During angiography, an anomalous left main was reported from the right coronary sinus. And during 2017, again, she had chest pain, so a new angiography was performed and 2 more drug-eluting stents were implanted in the right coronary artery. Our patient has also peripheral arterial disease. She had PTA with implantation of stents in the arteria femoralis superficialis dextra and sinistra during 2015 and 2016, while during 2017, a femoral-popliteal bypass reconstruction was performed. She has arterial hypertension, dyslipidemia, diabetes mellitus complicated with diabetic polyneuropathy, and renal failure stage 3B with a secondary anemia. So this is the ambulatory therapy which she came to our hospital. From her laboratory findings, you can see an iron deficiency anemia, creatinine levels which are high. High sensitive troponin is normal, and she has high levels of NT-proBNP. From the echocardiography, we have apical hypoakinesia, left ventricular ejection fraction is okay, it's 53%, and she has mitral regurgitation. Her Holter ECG showed 1 episode of sustained ventricular tachycardia with heart rate 200 beats per minute. So what are the guidelines saying about anomalous aortic origin of the coronary artery? Usually, we should perform first a non-pharmacological functional imaging in order to confirm or exclude myocardial ischemia. In patients who have typical angina symptoms and present evidence of stress-induced myocardial ischemia, or they have a high-risk anatomy, surgery is recommended as a first line of treatment. In patients who are symptomatic but who has evidence of myocardial ischemia or high-risk anatomy, again, surgery is recommended. And in young patients, we could consider surgery if even though without myocardial ischemia or high-risk anatomy. Our patient is very old. We know that she has atherosclerosis. She had stent implantation during the years. She has peripheral arterial disease. We could perform a CT scanner in order to check if she has also high-risk anatomy, but we decided to perform directly an angiography. And as you can see, the right coronary artery is okay. The left main tract is originating from the right coronary artery, and here we can see a significant osteoproximal lesion on the LAD with heavy calcinosis. So the initial plan was to perform rotablation with 1.5 millimeters rotablator, but during cannulation of the right coronary artery with the ampuads, her blood pressure dropped and she had chest pain. So we decided to change our strategy, and we used the rotablator 1.25 millimeters with the help of guide Ziwa. Then we decided to perform also a shock wave with a 3.0 balloon, but after 50 shocks, the balloon ruptured. So we decided then to do a predilation with an NC balloon in the beginning, 3.0, 12 millimeters. As you can see on the image on your right, the balloon ruptured after inflation. So we decided to use a scoring balloon, 3.0, 12, 20 millimeters, which we inflated up to 20 atmospheres. So this was the result after using the scoring balloon. And we implanted the stent 2.75, 26 millimeters, up to 26 atmospheres it was inflated. And this was the result. Then we post-dilated with a 3.0 balloon, 12 millimeters, to 26 atmospheres. And this is the final result to our patient. So the anomalous origin of the coronary arteries is usually a very rare finding. Statistically, the incidence is 0.03%, and usually it's benign. Only the left main passing through the pulmonary trunk and the aorta increases the risk of serious complications like angina, myocardial infarction, syncope, ventricular tachycardia, in the absence of atherosclerosis. So what we should think next about our patient? Should we think about defibrillation, ICD implantation? Our experts are saying that in elderly patients in whom a benefit from the defibrillator is not expected due to the age and the comorbidities, omission of ICD implantation for primary prevention may be considered. And this is the therapy with which we dehospitalize our patient. Several months after the hospitalization, the patient didn't have any chest pain. She didn't have any syncopes, so we left here with this therapy. Thank you for your attention.
So the anatomy you showed is extremely rare.
Yes,
The left coronary artery can come from the right sinus,
yes,
but more frequently with the LAD going through between the aorta and the pulmonary artery, and the circumflex just behind the
Yes.
aorta. So you have the whole left coronary artery behind the aorta. So there is no risk of the pulmonary artery and the aorta. So no risk of this.
okay,
What is a risky situation is when the vessel, the LAD is coming between pulmonary artery and aorta,
Yes.
especially when it's going into myocardium. Another aspect which is dangerous, which is the right coronary artery taking off between the pulmonary artery and the aorta. So this situation has to be treated for surgery, for
Yes.
example. But this case, in my opinion, there is no risk. So what was very interesting was the way you implanted the stent between what we call that, the distal left main and LAD. You have no protection in the circumflex. I can accept that. But normally, there is two diameters. There is the diameter of the distal left main and the diameter of the circumflex. So now you have created a bifurcation with two diameters, not three diameters. So what I would have done is a crossover stenting and a pod.
But we did a pod with a 3O balloon.
I have not seen the scale. So just proximate to the surf, I have not seen it. Yeah, you did it. If you did it, it's perfect. No problem.
Maybe we didn't show it, but we did.
Yeah. This is crossover.
And it's a very nice case. Congratulations. I think this is the second one that we saw during this meeting. I think Dr.
Yes,
Vasily
yes,
presented one yesterday.
yes.
And referring to the point of, let's say, the course of the left main and the LAD, usually you expect to see these kind of problems much younger age when it's an abnormal course. Yes.
Critical aspect, which is common for the circumflex behind the aorta and this. Personally, I was not using Amplatz, I was using multipurpose. Which is more, you can have deeper incubation if you need. With an Amplatz, you can do a deep incubation.
The problem in this case is because yesterday Dr. Mileva demonstrated what the 34-year-old patient was, which we demonstrated yesterday with there are two problems. One is the crossing between the pulmonary artery and the aorta, and the second one is cannulation, because whatever you want use to cannulate this single coronary, the chance of arrhythmia and problematic ischemia is much larger because you are occluding practically both coronary arteries. The total coronary tree could be closed in a given moment, not just one artery.
I would like to ask a comment from the operators regarding the use of guiding catheter extension with rotablation.
Yeah.
How did you do the sequence of the materials? Because the people have to know that you first of all wiring and then you advance the guiding catheter extension rather than otherwise. So there were many nice technical aspects in this case. Please comment if you want.
Well,
The question was about you did the rotablation using a guiding catheter extension.
yeah.
What is the sequence of the the wire, this, that, how, and the guiding catheter extension, and then so there is this a nice technical aspect.
How I made it, because it was not planned to do it. I mean, I wanted to do a 1.5 with the 7 French guiding, but as Dobre said, when you cannulate with the 7 French guiding this artery, the woman is with 50 blood pressure. So it was first introducing the guiding extension and then the wire and the burr.
Well, that's not the right sequence, of course. You were lucky because there is always a risk that if you put the guiding catheter extension and then you wire, that you might go outside the.
But it was over a microcat.
No, wire, then
Yeah, that's what over the wire. Yeah, okay, that's good. Very good.
Very nice.
Thank you.
next one.
The next case is Dr. Nounov, please.
Okay, thank you for the opportunity to present you a case from our practice. It's about a female patient, 70 years old, with risk factors for the coronary artery disease, arterial hypertension, diabetes, hyperlipemia, with clinical presentation, with acceleration of angina for the last few days, and with a heart failure. She has a known coronary artery disease with the previous known STEMI on May 25, with primary PCI and 1 death, 3.0 to 9 on the proximal LAD, and staged PCA with 2 stents on the circumflex artery 1 month later in another center. Oh, sorry. On the ECGs with the negative T waves on the precordial leads, on the echo with injection fractions with 45 and anterior hypokinesia, and up to 2nd grade mitral regurgitation. On the laboratory findings, nothing interesting. Maybe a little bit high sensitive troponin was elevated, but we performed coronary angiography. And this is the right coronary artery with the distal diffuse significant lesion. And the left coronary system with diffuse calcified lesion and at the proximal segment of the. on the proximality with bifurcation with the first diagonal branch and ostial severe calcified lesion on the LAD. For sure it was a significant lesion, but usually we perform a functional assessment with, in LAD with DPR 0.83 and FFR 0.74. We perform IVUS with, this is just for prepare for the intervention. And we decide to do a complex intervention on the LAD, left main, and first diagonal branch. Radial approach, guiding catheter XB, 3.56 French, 2 wires in the LAD and in the diagonal branch. A series of predilatations with several non-compliant balloons, and we had problem with the ostium in the ostium of the LAD. There was a waste of the NSIC balloon 3.515, and we tried with non-compliant scoring balloon 3.512, and we did success with the good opening on the balloon. And after that, we implanted stent who was overlapping with the previous implanted stent, 3.024 on the LAD, with covering the bifurcation with the LED, recrossing, rewiring, and POBA on the diagonal branch. TIMI flow was okay, but we decided to do balloon dilatation on the osteoproximal diagonal branch with NC balloon 2.15 with good result. After that, rewiring, we were wiring the circumflex artery, and we implanted the stent on the left main to the LAD, 3.518, and after that, pot on the left main with the NC balloon, 4.028, and this is our final result, TIMI flow to the diagonal branch, LAD, and circumflex artery with no compromising the ostium of the circumflex artery. And we finished the case. We discharged the patient totally asymptomatic on the optimal medical therapy on the second day after the procedure. And we did the follow-up clinically 1 month later with almost no angina and really improvement of the symptoms of the patients, and we planned the functional assessment on the right coronary artery for the next month. Thank you for the attention.
So congratulations, the case is very good. My only note in this case is just usage of IVUS. Because always, if Robert Gill was here, he will jump immediately regarding the assessment of the left main result with IVUS.
Yes.
And this is why we switched, and maybe in the last year and a half, we are using almost entirely on all left main bifurcations, 5.0 and larger balloons, just to be sure that the left main is optimal. If somebody don't want to use IVUS, just to be sure, because 3.5 and 3.0 in circumflex, this is 6.5, and 70% of 6.5 is around 4.5 at least. As a diameter, if I calculate the Finet formula correctly, so yes. This is at least 4.5, and I'm always going a little bit up with the 5.0 balloon for the left main in similar cases.
Yeah, thank you.
That's a good comment. And finally, what we know from speaking in interventional cardiology, probably IVUS is the only device that improves prognosis in this patient, even not stents and so on.
This is just to finish the comment. Here is not the case about the malposition of the stent.
Yeah.
Here is the case of under expansion of the stent. Minimal stented area. Yes, this is the point.
What I have to say is following this idea. I saw that you did POT with a non-compliant balloon.
Yes.
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 So what is the potential of overdilation of a non-compliant balloon is 1/4 millimeter. So if you made just a small mistake for sizing the branch, you are not able to reach the wall. So you have the vessel floating. I think why we do POT with semi-compliant, because we have a potential for increasing the diameter at least 0.5 millimeter, or 75% more. So I think this, for me, is among all the rules of UBC. You may think this is very complex. No, if you do systematic, after 10 cases, very systematic, then the nurse is giving the semi-compliant. You don't have to ask. So semi-compliant for POT.
I'm a little bit against that in this case, concretely for this one, because of calcification, because there is a massive calcification, and sometimes because of this one.
First, maybe we can ask a question in the room. What is the pressure to deploy a stent? What is the pressure necessary to deploying a stent? I mean, follows the inflation of the balloon, you know? The pressure is 0.5 atmosphere. 0.5 atmosphere. So we don't use a high pressure balloon to open a stent. The stent is open with, whatever the balloon you use will you open. So we use non-compliant balloon. This is to prepare and to treat the wall, not to open a stent. So non-compliant, yes, to prepare the lesion, to give the diameter, the ideal diameter, or the two diameters, the distal one and the POT, you have to use semi-compliant. Imagine this is, the diameter is 3.8. If you take a 3.85, if you take a semi-compliant, a non-compliant 3.5, you are not reaching the wall. Yeah. If you say the same balloon, semi-compliant, you can inflate until you don't see the puff. Simple. So simple.
Okay.
Okay.
Thank you.
So congratulations. Yes, absolutely. With so much calcium.
There is probably a fellow, Dobry Vasiliev, is going to.
By the way, this is a case which I made 2 days ago, maybe actually 3 days ago. And I prepared the slides this early morning at 7 o'clock. So this 45-year-old male patient with high-grade stable angina from more than 4-5 months, maybe more than half a year, with anterior MI in 2023, probably from the patient history. The lab was okay with normal GFR. There was anterior hypokinesia and ejection fraction is 48%. And the patient came in our center in December 2025. And he had the CTO on the LAD. We offered him mid-cap off-pump surgery, but he refused. And he decided to come for PCI on the CTO of the LAD. As you can see, there was a occluded LAD completed from the right side with a very good collateralization and diffuse disease of the LAD below the occlusion. So this is how the left coronary artery looks like. And the catch here is actually this is it looks that the vessel is patent at the proximal part, but actually this is a huge bridging collateral net. And it took me almost 10 minutes to go into the first septal, and that was because the wiring was really hard. This is ultimate wire with the fine cross catheter. So after that, I took Sasuke just to go into the proximal cap of the CTO, and this is Gaia third, and the result from Gaia third was nothing, and then switched to Confianza Pro 12, which was not very successful. From the spider view, which I place here just to appreciate the anatomy of this bifurcation. It's actually trifurcation because of the septal also there. And this is the tip injection at the proximal cap after wiring with Confianza Pro. Then we went distally and the wire stopped there. So this is the second tip injection, and the Guadius X went into the diagonal. So the wire was exchanged for the regular wire, and that was the result after ballooning with the 1.5 balloon to the diagonal. Then we made a balloon dilatation with the cutting balloon, Revo Edge. This is a new type, a new generation of cutting balloon all over the proximal part of the diagonal branch and the LAD. And after that, we made the contralateral injection with the antegrade injection, and it was visible this picture. Then with Sasuke and first Confianza Pro, then switched to Guadius X again. It was possible to wire the LAD, and after switching to the regular wire, again we made several balloon inflations, and again cutting balloon on the diagonal 2.5 to 15, then again cutting balloon on the LAD over the length of the occlusion up to the ostium. The LAD was stented at proximal part. As I said yesterday, I'm not keen to implant any stents below the mid LAD, so that was the result after stenting. The first diagonal disappeared. Probably that was the reason for reaction of if. And with the 4.0 balloon, we post-dilated the whole stent. Then the 2.5 balloon to 55 millimeter length, and 2.5 to 25 millimeter kissing inflation was performed in the LAD and diagonal. The first diagonal was opened with ultimate wire just to restore the flow, and kissing inflation with 4.0 balloon and 2.0 balloon into the LAD. I missed the scene where we treated the LAD with 3.0 to 40 DCB, and 2.5 balloon was used for diagonal. So we left the patient so because of the prolonged procedure and contrast more than 200 milliliters. And when I reached the 200 milliliters, I'm stopping to think for stop and to stage the procedure. But that was the final result at the end of the procedure, and we called the patient after 1 month for follow-up just to see the result. So that was the case. I know what could be the approach. It is pretty clear.
No, it's...
No, it is not that. Excuse me. Because if you go retrograde, it is not an easy task to go retrograde from the to the right. Am I right?
The comment was not in the direction of the retrograde or not, but we were in Carlino 2 days ago with Mauro Carlino in Cairo, and he did this kind of procedures of multi-injections. And what I realized, one was failed, one was successful, is that I have the feeling that you inject more contrast than they recommend. Because essentially you created what in the past was called the start cloud injection. Today I saw, or 2 days ago, I saw that they inject less than 0.5 millimeter. Less than half, in a very low rate. So
this is 0.5 milliliter. This
yeah,
is
but the contrast that comes out of it, it looks much more. That means that even if you inject the right amount, you inject too forcefully. So if you see these injections, then you see an extremely minimal contrast getting out of the catheter and geographically. So the rate and so that's exactly what I recommend. So the dissective plane that is being caused by the contrast is actually minimal. It's just losing the tissue rather than anything else. This was much more than what you would expect to see in the way that they do it contemporary. That's point one. The second thing is that, as I told you, I am not a very big pro of these kind of injections personally, which doesn't mean that I'm correct. I prefer the retrogrades in this scenario, but all in all, I think that as a strategy, what you followed by recovering all branches and trying to avoid actually the distal bifurcation is, in my view, a very senior decision, and I'm pretty sure that the flow will be good and that the patient is going to be asymptomatic. Simply, if you do the follow-up in 1 month and you see the result with the remaining dissection, I think that it should remain without any further treatment as far as the flow is symmetry.
A nice investment procedure, sure. And this is the evolution of this hydraulic dissection. In fact, George mentioned that these two differences, small amount, injecting very slow, and the third is that they claim that they use it not as a bayout as Carlino used it, but they use it as a primary
No,
strategy.
no, this was primary strategy anymore. It's not bailout. It's primary
I
strategy.
mean, this is the difference of the
Yeah.
evolution because Carlino used it as a bailout, and nowadays it is intentionally.
Exactly.
Yeah, and actually, the multi-injection is a rule, 5, even 6 injections. But as far as I see, I mean, as I told you, the contrast that comes out of the microcatheter.
What you see, just that was because of the next injection, which is this one, was because of the puffing.
No, no.
After that,
I know.
and
but that's,
that was,
that's exactly what I mean.
Yes.
You see both of these injections, it doesn't matter. I was referring to the first one. The first one is already too much of a distraction of the subintimal space, too much.
this one.
Yeah. It's already.
This is
because-
septo.
Yeah, you can see that it is a dissection, that it is to their view. It's because it's you see that it is extending laterally. So that creates a bigger subintimal space from what you want for your wire.
Okay?
I cannot do it, that's why I don't do it, because I tend to inject more, and that, like you, in this case. And I have discussed with him extensively, even the 0.5 millimeter is too much. So essentially they say that you inject, and the contrast penetration, if you see it, your contrast is penetrating, is it 3-4 millimeters? It is, correct?
Yes.
Yeah, it's too much.
Okay. It could be.
According to their saying.
This is the next one, and you can see that there is no even a clue from the previous contrast. There is no staining. This is the point of previous injection, and this is the next one. And here, the next ugly picture is because of the injection in the middle, and this is from bridging collaterals, which is going into this one. But anyway, just
No, it's a discussion about taking place into the direction of, let's say, all these dissection reentry techniques that are being proposed now, they have a kind of subjectivity about how you perform the procedure.
exactly.
And that's why
Huge.
that's what I don't like personally. I want, but as I told you, I want the procedures to be controlled. And I do believe that the retrograde procedures are more controlled as far as you can perform them properly. And this has to do with the numbers. And, but the case, one consideration of mine, because I wasn't there to handle the wires, if the lesion is impenetrable at the bottom line, it is what it is.
Yeah.
And then you went up to rightfully, you did a kind of an undergrade wire escalation. You went from 3 grams to 6 grams.
It
You
was
went to 12
very,
grams.
very stiff for my surprise,
Yes.
because it was a young patient,
Yes.
and it was very difficult to penetrate with Gaia Next 3 and
Yes.
then the Confianza Pro
No, exactly.
12, and it was
That's
very.
exactly the comment that I made. So you followed all the rules of the undergrade wire escalation.
Mhm.
You went from low, mid to stiff range wires. And then actually it's a decision to make whether you want to
Yeah.
go in a dissection reentry mode or retrograde or whatever.
Exactly.
But it was a well thought procedure on the planning. So the technical details of the contrast, as I told you, I don't have it personally. I tried a couple of times and I dissect too much.
I have to agree that probably the first incident is spontaneous dissection because the right is absolutely free, and you have these rails in the LAD. Probably this is recognized thrombosis, and the patient is young.
No, here occlusion was from the very ostium of the LED.
Yeah.
And it was very, very long
Yeah,
occlusion.
this is
It is a several centimeters occlusion. This is not, it looks like very...
One other comment, sorry Valerie to interrupt you, one other comment beyond the contrast injection, that might be because, as I told you, you did the injections, you see. The other thing that they are doing and what they are advocating is that the wire manipulation before the contrast injection should be minimal.
Minimal, yes.
So that means that maybe on an effort to go in a wire escalation, this has, because when you go with Confianza and you push it, you manipulate the proximal cap on a certain level. Because the wire, of course, didn't penetrate all the way, but it did dissect, in brackets, or modify the proximal
Exactly.
cap. And then, essentially, that's what they say. If you do that, and you have created already a small micro dissection in the proximal cap, any kind of contrast injection might spread. So it might not be what I said of the flow or the rate that you did, but because maybe the wire was manipulated a little bit more based on your strategy, and then there was already some subintimal that was expanded. So if someone has to follow this, when they do it with minimal wire manipulation, you insert a microcatheter into the place, small injection, slow flow. But if you dissect the place, even if you don't see it, I'm not talking about this case, generally speaking, then it's better to follow a different strategy in brackets, yeah. And you follow, generally speaking, with software, but no, I saw that they're using
The
quite a
rule,
lot.
the consequence, the algorithm is what I applied in general for this one, because this is type 2B dissection, the type 2B dissection, which is according to the classification of Carlino, if we follow this one, and it is not possible because the proximal cap was very stiff. It is not possible to introduce the microcatheter without some dissection. Just if you go to penetrate, the wire is much thinner than the microcatheter. So you cannot introduce the microcatheter inside the plaque without some dissection. This is
But that's the limitation
inevitable.
of the technique also.
Yes.
That's one of the limitations of the contrast injections, or how they call it now. Anyway, it was a very nice demonstration. Finally, you were able to solve the calcification. You were able to get both branches, recover the third branch, and I fully agree with the strategy of non-stenting.
No, this is should not be. I just placed the stent just to stabilize the proximal LAD. DCB, because I was sure that I'm in the lumen, but subintimal DCB is not a good idea, as we discussed before about the aneurysms.
Thanks to Dobry. And now Dr. Parapunova is going to present our case. It is probably its places outside the box, but I think it will be interesting.
Last but not least, I'm going to present a case. It's a very much challenging case, a TAVI complication case, which we did perform more than a year ago. This is a 76-year-old male patient with heart failure, severe heart failure symptoms, high NIHA functional class, with typical risk factors for coronary artery disease, a smoker with very poor condition, peripheral artery disease, and chronic obstructive pulmonary disease, so severe comorbidity. When we did meet the patient for the first time and perform echocardiography, it was severe aortic stenosis with very much high gradient as well as peak and mean gradient, our VTI below 1.0, and preserved ejection fraction, left ventricle hypertrophy, which was very much expected. We did perform angio. It was non-obstructive coronary disease, nothing specific and interesting, so we did not put pictures here, and Euroscore, which was more than 4. So we did discuss on her team to be a TAVI patient, and after giving us a permission, we did the procedure. Actually, from these pictures, you can appreciate the severely calcified aortic valve, as well as on the CT pictures. This is tricuspid aortic valve with being severely calcified. We did perform TAVI. This is left femoral artery, Chereau-guided puncture, 6 French, and right femoral artery, which is angio-guided puncture, expectedly be 14 French with Manta closure device planned, predilatation 24-40 balloon, rapid pacing with rupture of the balloon, as you can observe on the video. We did We did want to take out the balloon, pulling out the balloon without any success. So the balloon did turn on its opposite side. It was very difficult to take out the balloon from the artery. So we did call the surgeons. They helped us performing open surgery access. And actually on the picture, this is a video from the surgery work. And they tracked the balloon. It was on its initial parts, as you can see on the below put it pictures. This is actually, excuse me, these are actually another photos. On the second photo, you can see the artery, which is absolutely ruptured in very, very poor condition, being damaged because of the pulling out of the balloon. And using this open access by surgeons, we did put the TAVI core valve Evolut 29. It was a successful procedure. This is the opening of the valve.
Because the bone ruptured and it's disintegrated, and it was not possible to pull it out from into the sheet. It is 14 French sheet. After that, we removed the sheet, cut it the bone, and removed the sheet just to try to extract it through the artery, but it was not possible, and then the surgeon comes. Sorry.
Actually, this is on this picture. No sheet, only the balloon before surgery, as it was explained by Professor Gelev. Here the opening of the valve. We did resume. It was a very nice final result. We did stop the procedure. The surgeons, this is the final result. The surgeons put a conduit in the femoral artery, and we did finish the procedure as we were thinking. It was a successful procedure. But the patient didn't feel very well in the next few days. He did go not very well within these days in a bad hemodynamic condition. It was blood loss, hemoglobin was lowering, but after that, the heart failure symptoms persisted, and echocardiographers did measure very high gradient through the prosthesis. It was more than 80 millimeters per mercury. So we did perform CT. CT told us poorly satisfying result in 3 days later, which were actually corresponding to severe heart failure symptoms of the patient. You can observe on the pictures the prosthesis, which is not very well opened. It might be because we did not perform predilatation exactly because of the balloon rupture. It might be because the valve was severely calcified and we did not post-dilate the valve. So we go on a second procedure in 3 days later. It was left radial artery 5 French, as well as left femoral artery, expectedly 14 French Manta closure device, and peak-to-peak gradient was more than 100 millimeters per mercury. So we did perform post-dilation with balloons 24 and 26 per 40, and here is our difficulty because till this moment here in Tukuda, as far as I'm concerned, in a lot of other hospitals in Bulgaria, there were no big inflators in their volume.
Usually, just we inflate the balloons with manual inflation. And we tried to do this several times, but no effect on this. And finally, we decided to follow the guidance. I mean, the recommendations of the balloon that you should reach 4 atmospheres. But we don't have that an inflator with such a big volume, and we took 2. Yes.
With this innovative method, which was successful till this moment. And this is the post-dilation of the valve. Here on the third video. Actually, this is the final result, which was more than satisfying. Final peak-to-peak gradient was less than 10 millimeters per mercury. And in a follow-up, the patient is going very well without any symptoms of severe heart failure till this moment. So in a conclusion, as you know, TAVI is robust, mature, and safe treatment of severe aortic stenosis in high-risk patients, as it was in our patient. it has become safer with improved technology, but specific risks remain, and vascular issues are ones of big five. Actually, they remain most frequent complications, very often corresponding to severely calcified peripheral arteries. And on the other hand, balloon rupture remain rare, but serious complication, often caused either by severe calcified stenosis of the valve or high-pressure inflation. It can cause as well as vascular injury, as it is in our case, and emergency surgery is ongoing, so teamwork is crucial. Thank you for your attention.
I think that that was really amazing final presentation for the anniversary 15th edition. Thank you so much for your patience and for your endurance. Thank you for all our international faculty. Thank you to Denica and her team. Thank you to our staff supporting us. Thank you guys for the transmissions. Everything was perfect. And I hope to see you next year again. Valery?
As always, it was our pleasure, and many thanks to the participants that were here steadily during these 2 long days, and really hope to see you next year. Thanks.